primarily the leukemia is a bone marrow-based disease. You have to differentiate it from the lymphoma, which is lymph node-based disease. And the leukemia is subdivided into acute and chronic. The acute leukemias, mostly they are composed of immature blood cells. But the chronic leukemias is mostly composed of mature myeloid or lymphoid cells. It's bone marrow-based disease. In this picture, you can see the bone marrow, which is replaced, which is hypercellular. And at high power, it's replaced by immature lymphocytes. So that it's called acute lymphoblastic leukemia. So the replacement of the bone marrow by immature lymphocytes, it's called acute lymphoblastic leukemia. And due to the dysfunction of the bone marrow, subsequently there is what we call it the pancytopenia, failure of hematopoiesis. There are anemia, leukopenia, and thrombocytopenia. In this picture, you can see what we call it the immature lymphoblast. ليش حكينا عنها immature? Due to the presence of the prominent nucleoli and high incineration. بالتالي, there is immature lymphoblast within the peripheral blood, which is called acute lymphoblastic leukemia. In general, the acute lymphoblastic leukemia, it is disease of childhood. يعني the majority of the patients, child, 3 to 5 years. But هذا لا يعني إنه ما بيجي بالكبار. الشباب هون إيش بيضحكوا؟ Immature lymphoblast present in the peripheral blood, so that it's called acute lymphoblastic leukemia. In this picture, بنلاحظ إنه ال NC ratio قلت, and there is a little more cytoplasm and the absence of prominent nucleoli. And it is mature lymphocytes within the peripheral blood. It's called chronic lymphocytic leukemia. It's chronic lymphocytic leukemia. It is disease of the adults, and it's the chronic things. They are usually indolent. يعني بتطول مع المريض. بتقعد مثلا 10-15 سنة. But acute lymphoblastic leukemia and acute myeloblastic leukemia, within 1 to 2 years, it will kill the patient, which is the main difference between the chronic and the acute things. In this picture, there is a characteristic thing presented. There is low NC ratio, so that it is chronic thing, mature thing, and the presence of cytoplasmic granules organized in our rods. It is characteristic of acute myelogenous leukemia. The presence of acute, our rods, it is characteristic of acute myelogenous leukemia. In this marrow also, it is hypercellular and replacing the normal components of the bone marrow, so that it will lead to what we call it the pancytopenia, the anemia.
ثلاثة ما فيش ثلاثة على الجهاز، شو أرقامكم؟ معلش تيجي تقعد هون.
In this picture, this is what we call it the acute myelogenous or myeloblastic leukemia. There are a high NC ratio and immature myelocytes. And in the background, there is what we call it the megakaryocyte, which is responsible. This is a bone marrow specimen, which is responsible for formation of the platelets. Next, in this picture, we can see granulocytes. The granulocytes, they are mature. The presence of the granules, it indicates the maturity. So that granulocytes mature within the peripheral blood smear, it's called chronic myelogenous leukemia. There are neutrophils, which is one of the granulocytes, and other neutrophils, we have eos and we have the basophils. And the most important differential, شو يعني differential diagnosis? It is the possible causes of this condition. It is presence of mature granulocytes within the peripheral blood smear. It could be what we call it the leukomoid reaction or chronic myelogenous leukemia. When they are increased in number, you have to differentiate. It's a chronic myelogenous leukemia or it is a leukomoid reaction. And the most important to differentiate, it is the leukocyte alkaline phosphatase, which is low in the CML and high in the leukomoid reactive. The leukomoid thing, it is not reactive benign thing. It's not malignant as the chronic myelogenous leukemia. In this picture هون بنقدر نشوف الجرانيولز بشكل أوضح. They are granules, mature granulocytes within the peripheral blood smear. It's indicator of chronic myelogenous leukemia. This is a characteristic translocation of the chronic myelogenous leukemia. There are 922 chromosomal translocation, which is responsible for formation of the BCR-ABL gene, which is called the Philadelphia chromosome. And in the cytogenetic analysis of this chromosome and the karyotyping, if you find 922 translocation, Philadelphia chromosome, it is characteristic for the CML. In this picture, مثل ما حكينا, the presence of granulocytes in the peripheral blood smear could be due to benign reactive condition, inflammatory or infectious condition, and mainly you can differentiate between the CML and the leukomoid reaction من خلال the leukocyte alkaline phosphatase. This is a leukocyte alkaline phosphatase immunohistochemical stain, and it is cytoplasmic. هاي اللي باللون الأحمر. This is a leukocyte alkaline phosphatase, which is high in the leukomoid reaction, so that the presence of the leukocyte alkaline phosphatase within this indicates this is benign, it is not malignant condition. This is a very characteristic appearance of leukocyte with cytoplasmic projections like hair. It's called a hairy cell leukemia. And this is presented عادة with non-specifically as a splenomegaly, pancytopenia, and bone marrow involvement. But this is characteristic of hairy cell leukemia with cytoplasmic projections. To another topic, this is on the lymph node. This is the normal architecture of the lymph node. بتلاحظوا بالصورة إنه there is a capsule in the upper part of the picture. تحتيها في lymphoid follicles with germinal centers. And in the subcapsular area there are draining sinuses that will, the first antigens that will come from out or things that will drain, it will drain into the subcapsular sinuses. Then the lymph, it will move from the subcapsular sinuses باتجاه الميدالا. And between the medulla and the germinal centers, there is what we call it the paracortical area. In the paracortical area, sometimes there's expansion of this zone, and subsequently it will aid you in diagnosis of lymphomatous disorders. In this picture, you can see a subcapsular sinus filled with red blood cells and the lymphoid follicle with activated germinal center. ليش بنحكي عن activated؟ لأنه pale center. When it's non-activated, it's called بتكون dark center. But pale center, activated germinal center. In this picture, there are, in the germinal center, there are variable components. And the presence of the variable components within the germinal center indicate the benignicity of this disease. And within this picture, you can see large cells filled with deepers. They are the macrophages of the germinal center. that has a specific name, which is called tangible body macrophages. مثل ما عندنا بالليفر الماكروفاج is called Kupffer cell. Within the germinal center, it's called tangible body macrophages. And this is higher view of large cells مقارنة بالlymphocytes which are filled with debris. And this is called tangible body macrophages, which are the macrophages of the germinal center or of the lymphoid follicle. In this picture, you can see mesenteric lymph nodes. And mesenteric nodes is my intestine. There is a large lymph nodes, مثل nodules, and they are matted lymph nodes مع بعض ملزقين, and there are some hemorrhage indicating there is a malignant thing within them. So that in large lymph nodes, grossly, you can guess it's a reactive or it's a malignant. But more importantly, you have to examine it under the microscope. This is one variant of the lymphomas. Lymphomas, they are subdivided into Hodgkin and non-Hodgkin lymphomas. And the non-Hodgkin lymphomas, they are subdivided into high-grade lymphoma and low-grade lymphoma. One of the low-grade lymphomas, what we call it the follicular lymphoma. In this picture, you can see a lot of follicles with non-activated germinal center. And the most important sign in this picture of malignancy, it's an extracapsular extension of the lymphoid infiltrate. And there are germinal center or lymphoid follicles. They are not confined to the cortical area. They are descended into the medullary area. بالتالي, this is characteristic of the small lymphocytic or follicular cell lymphoma, which is called the follicular lymphoma. In this picture, a clear indicator of malignancy, which is an extracapsular extension of the lymphocytes in the adipose tissue اللي And this is diffuse effacement of the nodal architecture. ممكن نعتبرها هي small lymphocytic, well-differentiated lymphocytic lymphoma. In this picture, we have in the right part, we have a normal liver parenchyma. And in the left side, there is small cell infiltrate within the liver parenchyma. And they are small lymphocytes. بالتالي, this is what we call it small cell lymphocytic lymphoma infiltrating within the liver. In this picture, you can see there is a large lymphocytes that diffuse replacement of the lymph node architecture. So that this is what we call it replacement. This is a specific immunocompromised individual, خاصة في الAIDS patients. Next. In this picture, you can see a large lymphocytes proliferating within the lymph node and not forming follicles. Large lymphocytes diffusely replacement with a prominent nucleoli. This is what we call it diffuse large B-cell lymphoma. And in order to be sure of the origin of the cells, they are highlighted by immunohistochemical study, CD19 and CD20. In this picture, this is bone marrow replaced by small blue cells. وبالتالي, there will be results. Sometimes the lymphoma, it could infiltrate the bone marrow. Either the lymphoma, it's lymph node-based disease, and sometimes could involve the bone marrow and lead to pancytopenias. In this picture, the Burkitt's lymphoma important causal relationship with what we call it the Epstein-Barr virus. The Epstein-Barr virus, it will infect the immunocompromised individuals, and it will lead to what we call it the Burkitt's lymphoma, which is high-grade lymphoma. And by this immunohistochemical study, there is a cytoplasmic staining of Epstein-Barr virus. And also, the Epstein-Barr virus, it will cause in the immunocompromised individuals what we call it the post-transplant lymphoproliferative disorder. This is an enlarged lymph node. You cannot guess what is the nature of the lymphoma just grossly, but this is an enlarged lymph node. Very important, the lymph node could be involved by infectious inflammatory disorder and could be involved by neoplastic malignant disorder. On the examination, لما تفحص المريض بيكون الليمف نود in the reactive inflammatory condition painful, tender, يعني بيكون فيها ألم. But the lymph node in the malignant condition, it's a painless thing, non-tender condition. In this lymph node, this is non-case of lung carcinoma. And there is replacement of the nodal architecture by this white thing. It is indicator that in the grossly, the lymph node is involved by something. And this is non-case of lung adenocarcinoma, and subsequently, this is metastasis that will involve the lymph node. This is a lymph node. There are glands abnormally placed within the lymph node. And إذا بتلاحظوا اتجاه الجلاندز, they are coming from the subcapsular sinuses باتجاه المظلة. وبالتالي this is metastatic adenocarcinoma within the lymph node. مثل ما lymph nodes involved by the neoplastic conditions, it could be involved also by infectious processes, like in the tuberculosis. مثل ما بتعرفوا tuberculosis, there is a caseous necrosis within tuberculosis. وين ما يكون في TB, there is caseous necrosis. And when it's present within the lymph node, this is what we call the tuberculous lymphadenitis. There is caseous necrosis within the lymph node. This is a specific condition for HIV/AIDS individuals, in which مثل ما بنلاحظ على flow cytometric analysis, there is deficiency or absence of CD4 plus cells. And subsequently, within the lymph node, there is follicular lysis within this lymph node. There is multinucleated giant cells large. There is a follicular lysis within the lymph node. Another topic that we call it the plasma cell neoplasms. The plasma cell neoplasms, we have the mature proliferation of the plasma cells within the bone marrow. This is what we call it, the multiple myeloma. And in this individual, this is a skull of dead patient that will show you punch out lesions that are characteristic for plasma cell proliferation within the bone marrow. This is what we call it, the bunch out lesions. This is a vertebral column, and here you can see the bunch out lesions within the bone of multiple myeloma patient. This is, in this low power, you can see it is diffusely replaced, the bone marrow, by some kind of cells, can be determined on low power only, on high power only. In this picture, you can see the mature lymphocytes, mature plasma cells within the bone marrow. They are proliferating, and the plasma cells, عادة, it will produce what we call it the immunoglobulins. And the immunoglobulins, عادة, we have kappa and lambda. But in malignant proliferation, there is only one, either kappa or lambda, that will appear in the blood, peripheral blood, so that we can do what we call it the serum protein electrophoresis in order to detect these light chains in the peripheral blood. In this picture, you can see the plasma cells, which the plasma cell there is a peripheral nucleus with cartwheel appearance of the nucleus, and there is a paranuclear hub. بتحس ببياض حول النيوكليوس. But also could be present the atypical plasma cells within this peripheral blood smear, as highlighted by the arrow. This is a lymph node patient presented with lymphadenopathy. This is abnormal, it's not normal, and only can determine the cause under the microscope. But under the microscope, this is determined as one form of lymphoma called the Hodgkin lymphoma. We have two types, Hodgkin and non-Hodgkin, and the Hodgkin lymphoma, it's a variant of the lymphoma. In this, you can see the liver, there is something infiltrating the liver, white spots. These are abnormal within the liver. So that this is involved by something, and under the microscope can be determined as Hodgkin lymphoma. In this picture, you can see a pink material that will divide the lymph node into nodules. That will form the nodules. And the nodules indicator this is one variant of the Hodgkin lymphoma called nodular sclerosing variant of the Hodgkin lymphoma. The pink material is collagen, and within this substance, there is a fibroblasts. At higher power, the pink material, its indicator, it's collagen, and the presence of the fibroblasts within them, spindle cells. This is a specific for the Hodgkin lymphoma, what we call it the lacunar cells, مثل خلايا تبعت الكارتلج. There is a clearing around the nucleus due to artifacts of the formalin, which is mostly present on the Hodgkin lymphoma of the nodular sclerosing variant. The typical cell of the Hodgkin lymphoma, what we call it the Reed-Sternberg cell, the RS cell, which is a binucleated cell with two prominent chiroidal nucleoli, which is indicate what we call it the owl eye appearance, مثل عيون البوم يعني. This is higher power of the typical cell for Hodgkin lymphoma. This is in the cell we have two nuclei and two prominent nucleoli inside. And this is very important to differentiate the Hodgkin lymphoma. The marker for the Reed-Sternberg cells, they are CD15, immunohistochemical study as highlighted in the picture on the right. This is for another form of Hodgkin lymphoma other than the nodular sclerosing variant called the mixed cellular Hodgkin lymphoma, in which there are a lot of the eosinophils and the plasma cells within the field. ليش mixed cellularity? We have typical RS cells and we have other cells. عشان هيك بنسميها mixed cellularity. We have a lot of eosinophils in this picture. اللي لهم red cytoplasm eosinophils. We have another two variants of Hodgkin lymphoma, either lymphocytic rich or lymphocytic depletion. And there is, in the lymphocytic rich Hodgkin lymphoma, there are paucity of RS cells. بالمقابل, in the lymphocytic depletion Hodgkin lymphoma, there are a lot of RS cells, which are highlighted by CD15 immunohistochemical stain. This is lymphocyte predominance, and there is RS cells within the nucleus, within the field. This is lymphocytic depletion, and there are a lot of RSF.